Good evening, one and all. This is Dr. Jude Vinoth, heading the Department of ER in Apollo Hospitals, Madurai. So, in this very fine evening, there is a wonderful talk awaits us all. The main idea of promoting this kind of academic events, especially by Yashoda Hospitals, is really wonderful. So the thing is, the topic today and the speaker today, I have the privilege of introducing my long-term close friend. And obviously, whenever we speak about a famous person, we usually used to say that there is no need of introducing him. But I will take the privilege of introducing my long-term friend, that is Dr. Srinath Kumar, who is the senior consultant and the group head and Department of Emergency Medicine, Yashoda Group of Hospitals. And he's also the treasurer of the International Federation of Emergency Medicine, the treasurer of Asian Society for Emergency Medicine, the associate editor for NJEM and EAJEM, and the National Academic Coordinator for ANBI. And he is also the chair in the Academic Council of our Society for Emergency Medicine India. And the topic would be no one wants to be a veg. Such an interesting topic and caption that they have given. And I have never wanted to be a veg in view of my diet. So let's see in what way it's getting correlated to the stroke. Stroke is one of the special entity of emergency medicine, the management of which has been revolutionized in the past 10 years. So let's go ahead and look forward towards Dr. Srinath. Srinath, it's over to you.
Thank you very much, Jude. It was a pleasure to be part of you. And as you mentioned, stroke is very important today in day-to-day activity, and we as emergency physicians should know in and out about stroke. That's the reason why we selected this topic. And every week, as part of the Yashoda family, we bring in webinars for you to look into the academics. Initially, many of us asked me, what do you mean by no one wants to be a veg? Is it regarding the diet? No, it's not regarding the diet, because if you don't treat the patients in stroke at that particular moment, you know what is going to happen. As emergency physicians, we all know if you don't treat the patient at the right time for a stroke patients. Regularly, I keep telling one thing. When a patient is there in the emergency department, that is always that there are three things which we all keep in mind. One is right patient. He has to reach the right place for the right treatment. Stroke. So stroke cannot be treated in every single hospital, but it needs a stroke-ready hospital. So worldwide, it is well known that stroke-ready hospitals are the one who treat the patient on stroke on time. So every emergency physician in this forum and who are viewing online, offline, so they all understand why this topic is very important. And as part of an academic, as a resident in any particular program, they have to know the management of stroke in the emergency department. So with this brief introduction, I would like to take you all in the journey of stroke over the next 45 minutes to 50 minutes. Any questions, feel free to type. My colleague, Dr. Naveen, who has been very helpful technically, and he is also very active in academically. So he notes down all the questions, and at the end of the session, we can take the questions, and I'm sure that I'll be able to answer for you. If not, I will send you back the replied messages as you request for the questions. And also there will be 3 interesting polls for you to answer, so that we will also understand what kind of the academics which is going on and whether it has been understood in the right way. And I would like to thank our beloved Dr. Pavan, who has been very helpful in this webinar program, and also Dr. Lingaya, who is our Director of Medical Services at Yashoda Hospitals. So thank you. So with this, we'll be moving into what's stroke. So we all know everything is beautiful when we are in nature, natural. So once something happens to us, we know what is going to happen. So when stroke happens, you know this is what the colorful becomes totally black. And we all know the causes for it, and we all know what is the etiology for it. So without looking into the modifiable factors, like today, most of the patients in related with diabetes, hypertension, or any other with comorbidities, they are the ones who are more vulnerable for stroke. So it is better that we take a pledge today and we keep ourselves right to be in the position not to be invaded by this stroke for us or for our patients. So what happens in a stroke? We know that the blood supply, the circle of Willis, which supplies the whole brain. So always I keep telling that pathophysiology is very important to know any kind of a treatment. So when pathophysiology, we understand that is the circle of Willis, which supplies the whole brain and collects the venous blood back. So this makes the whole nervous system to be intact. And we know that whenever there is a blood supply hampering, or whenever there is something increased in the brain, so then the natural process, what happens, we understand. So what happens is when there is a block in the vessel, let it be like a cardium. I keep asking, how many of you know the treatment? There is a treatment for stroke. Common man is not aware of the treatment of the stroke. But whenever there is a chest pain, they know that they have to visit the hospital, get an ECG done, get an echocardiogram done. But when there is a stroke, they usually say that, is there a treatment for it? Yes, it is there a treatment. As we emergency physicians, doctors, healthcare providers, nurses, paramedics, we should bring in an awareness that stroke is a treatable condition. If they come to the right place at the right time, so the mechanism of treatment, everything will be followed upon. So we know that the whole black, when there is a good blood supply, there is a red color. And when there is no blood supply, whenever there is a block in the vessel, it becomes black. So this is what is going to happen when you look into. Now, what are the types of stroke? There is major problem. That is, one is the 85% belong to the infarct group and 15% belong to the bleed group. That is the intracranial hemorrhage, or it can be anywhere. So our main target is those patients who come with infarct. That is the reason why we target these patients early and give the treatment as early. So the need for speed is important. That is the reason why every time they write a caption, act fast in stroke. And no one wants to like to be a veg, that is in the vegetative state. That is what that means, the caption means. So you should act fast. Now, what do you mean by acting fast? We all know that time is brain, time is money, time is this, time is that. But we emergency physicians know every second is important. Let it be a cardiac arrest, let it be a myocardial infarction, let it be a stroke, let it be a sepsis. So every second matters when you are treating these patients. And it is said that if you don't treat the patient by even 1 single minute, we will be losing approximately 1.9 million neurons. That is equal to 12 kilometers from the long myelinated fibers. So that is the reason why we have to be very, very careful, very speed in action, and we emergency physicians are always known for that adrenaline rush. So what happens if you don't treat? If you leave the patient like that, it becomes inflammation and apoptosis, which happens over a period of time. Now, stroke awareness is very important, like what I said in the this one, because the creation of awareness among the public is very important in treatment of the stroke patients and avoiding delays. That is the reason where every hospital has developed a stroke pathway and there is a code stroke, because every minute is important. So I am sure that the people who are watching this will develop a stroke pathway if you are not developed, and if you have already developed, I'll be telling you in my next slides what is important. Now, then once you create this awareness, there is requirement for identification. If you don't identify the illness, you are not going to treat the patient. That is the reason why identification is very, very important for these patients, stroke patients. And when you look into the identification, you have to notify. So we emergency departments are aware that there are three parts every time. First is the pre-hospital care. Second is the triaging process. And third is your emergency department once the patient comes into. So once when you assess the patient, you get a notification, you dispatch the ambulance. You dispatch the ambulance with the paramedic and the doctor because they start the treatment at the house itself. It is not that the emergency medicine is starting at your emergency department. It starts with your house. So they will be notifying you in the emergency department regarding the condition of the patient. So that gives more and more advantage the people who are staying in the hospital receiving the call so that they can make everything ready, take the patient directly to the CT scan if required. And once there is a notification the ambulance has gone there and they picked up the patient, it is the responsibility that the maneuvering or giving the treatment in the ambulance or delaying the time in the house is not required. They should be transported directly, safely to the hospital, which is ready to receive the patient and treat the patient. So that is another important step for the residents whom they have to identify. So identifying a stroke, we all know there are multiple terminologies, but what is important is be fast. We have the adrenergic rush. We know that we have to be fast and we know what is every single letter in this. B is nothing but losing your balance. When a patient says that there is dizziness, giddiness, balance is lost. That means that again, there is a problem. What is E? We all know that the eye movement is dropped. There is a drooping of the eyelids. That is the next thing which happens. Now, face droop. So we all know when we have to smile, we know how we smile. When there is no smile on one side, there is a deviation. That means that there is a facial droop. So then arms, you ask the patient to keep the arms straight and one of the arm is drifting down. That means that the patient has a stroke. Or even when you ask for speaking, now I am speaking to you like maybe correctly. Whenever I have a trickling, that is what happened to me. That means that there is a speech defect. Who is speaking normally suddenly becomes abnormal. That is the time when they have to pick it up. Lastly, the T, that is time. You have to call. So we all know 108, 112 is a nationalized number for calling for an ambulance and having the pre-hospital services. So this be fast is very important in stroke. But accordingly, not all patients who have these symptoms cannot have a stroke. Sometimes many things can mimic a stroke, like alcohol intoxication, cerebral infections, drug toxicity, epidural hematomas, hypoglycemia, metabolic disorders, migraines, brain tumors, hypertensive encephalopathy, post-ictal phase of seizures. So these are the stroke mimics, which we have to be careful. How can you be careful? That is the reason why when the pre-hospital dispatches happen and the doctor and the nurse is going there, so they can pick up 50% of them when they're shifting the patient to the in the ambulance. You can just do a simple glucose levels, which will give you an idea whether the patient is in hypoglycemia or not. It is always good when they are shifting the patient, if they can have an IV cannula, color the samples because they're well versed what they have to get in. So that brings down at least 50% of the work in the emergency department. So that is what is an important thing. The other thing is a TIA or a mini stroke, which happens with temporary defects only, or there is a recurrence of attack, or mostly no, there is no permanent damage. Or sometimes what happens is there can be a warning signs of stroke. So what do you mean by warning signs of stroke? Somebody having headache, somebody having dizziness or giddiness like this. So these symptoms are some of them which can lead you that, okay, this can be a stroke, but mind you, whatever it is better to get the stroke pathway, get the investigations done so that you have ruled out the cause. Organic cause has been ruled out. Only then you can name them as PIA or mini stroke. So this part is very, very important in the emergency department. And then what is important is when was the patient found normal previously? That point zero, the time of zero is very important. Like say, if the patient was normal at 4 p.m., now the time is around 6:15 p.m. That means that the window is already started and the patient has already 2 hours and 15 minutes is the time. So that is what is very, very important. Adapting the 0 minute is important for the treatment purposes. And many times what happens is my dad was lying down, my mom is lying down. When she woke up, there is signs of stroke. Should we take for the treatment? Yes, we all know the treatment is there. Now, that is the reason why the window period, which as per the AHA guidelines, is still between 3 to 4.5 hours. But there are n number of researches which have shown that the up to 24 hours, you can extend the window period and look into what kind of a treatment you can be given. So this thing, as we all have to keep in our mind and do the treatment accordingly. Now, what is the thing now? So I just wanted to run one question here so that we can look into the polls and see what kind of an answer we are going to look into. Hope all of you are seeing the question.
Yes, sir.
Okay, you can answer the poll. The time starts now. We'll give you about 40 seconds. Which of these mnemonics in identifying a stroke? Very good. I can see that most of you are answering rightly. Thank you very much. So we'll be ending the poll. So we saw the poll result. That is good. That be fast is the answer. So thank you all. So we'll continue with this. So good. Now, what is the importance? How are you going to assess the patient? What are the things which is important as management issues? So important thing is as emergency physicians, we all know that airway, breathing, circulation, disability, exposure. And what is the time limit? You have to have only 60 minutes. That is 60 into 60 is 3,600 seconds. That's it. You have this much of a time in your emergency department. You have to decide whether it is stroke. You have to look into and say that, okay, this patient has go to CT room. All the things should happen. Now, individually, can I do anything? No, I cannot do. As I mentioned in my first this one, teamwork is very important in emergency department. Without a teamwork, it is nothing going to happen. So what is your team here? The emergency physician, the neurophysician, neurosurgeon, OT, radiology, pharmacy, finance, all these things should be integrated. And then either you have a PA system or a EP-PAC system. You can have a code number which can activate, and you can say that there is a stroke patient in your emergency department. So that all the people who are involved in the management of a stroke will understand that the patient is there and the treatment is important for this, and they come as a team and they will monitor the patient. Whatever is required can be done at the earliest phase. This is the most important teamwork which is bound, and you can see that every step which I'm showing you will be important and how you can take it forward. Algorithm is very important with timelines. What time the patient has come, what time the patient has been shifted to CT scan, what time you have started the giving the drug. So these three parts should be within 60 minutes. That is what is your timeline. And then There is an NIHSS score worksheet, which I'll be sharing you in the next one. The third part is whether you can give antipaste or not. That is again the third question. Then what is the doses? Lastly, you're monitoring if the patient is having hemorrhage, what you are supposed to do. So these are the things which you have to keep in your mind. Like what I said, airway, breathing, circulation is very, very important. When you're looking into the circulation, when you're putting the IV line, collect for the samples, especially your complete blood picture, the liver function test, coagulation profile, which is very important, and your renal function test. Everything should be available. The test you send within 20 minutes, the report should be in your hand. Because sometimes the coagulation is deranged, you may not be able to give the drug. So then it is not possible. So that is the reason why the lab should be activated along with your stroke protocol. So that is the reason why you see, if possible, get a baseline ECG. If not, no problem. Then CT scan is the golden one, which is important to get an image and look into whether this patient is having a infarct or a bleed. Because only in patients with infarct, you're going to treat with a thrombolytic agent. If there is a bleed, the neurosurgeon will take over and do the best thing, what you have to. But within what time you have to ship the patient to the CT scan? Within 10 minutes, the patient should be in the CT room, and within 20 to 25 minutes, the report should be on. And many times, many hospitals have started giving the loading dose, that is the initial dosage, which has to be given as a thrombolytic agent in the radiology room itself. So that is given much good results than shifting back the patient to the emergency department or critical care unit and then starting. There's a bleed within that, within the CT room itself. You can always activate your neurosurgery colleagues and see that there is a drift in the central line. That is if there is a drift in the central line, then automatically this patient can be taken up for the craniotomy or required surgeries as per the neurosurgeon. Now, what is the oxygen levels which we are comfortable? Any patient above 94% of oxygen is good enough. Whenever it is less than that, then you try to bring the oxygen levels, saturations to 94%. And whenever there is an airway compromise, don't hesitate to put the endotracheal tube. Invasive ventilation is the next protocol, because if the patient is GCS is less than 8, if you take the patient to the CT room, he vomits, then there is aspiration, patient can die or collapse there itself. So ensure that the airway is under your control, which is very important. Without controlling the airway, don't shift the patient to any other treatment area. And hyperbaric oxygen, is there a role? Yes, only in case of air embolism, which may be a cause of acute ischemic stroke. Otherwise, there is no role of hyperbaric oxygen. Now, if the patient has hypovolemia, hypotension, please start the fluids accordingly or inotropic agents. What is a contraindication? What is my limit of blood pressure? The systolic blood pressure level should be less than 185 millimeters of mercury, and diastolic blood pressure should be 110 millimeters of mercury. What are the best agents to control the blood pressure? What agents are you going to give? The best agent is your beta blocker, which is selective, cardio-selective beta blocker is very important. That is your labetalol is the most important drug. Don't try with any other drug like giving a calcigard or beta or esmolol or any other drug, which is metoprolol. These are not of any effect in these particular cases, because we know that the artery which is the culprit, not the vein. So if you give again nitroglycerin, again it is dangerous for the patient, because it is going to reduce your preload. When there is a preload detection, there will be hypovolemia and patient can go in for hypotension, which is very dangerous for these patients. Hence, you should be very selective when you want to reduce the blood pressure. Use levotalol, nicardipine, or clevidipine. These are the 3 drugs which you have to keep in your mind, and don't give anything else. And whenever the blood pressure, the diastolic blood pressure is unable to be controlled, then the last option is sodium nitroprusside. So first drug is levotalol, last drug is sodium nitroprusside. Now, what next? If the temperature is high, hyperthermia, only then you control the temperature. hypothermia is very, very dangerous for these patients. Even in your emergency department, if you're keeping 18 degrees, 20 degrees, it is not good for the patient. Keep it at a room temperature, at least 24 to 25 degrees to maintain euthermia of the patient. That is another important thing which we are seeing commonly these days. Next thing is hypoglycemia. Hypoglycemia is very bad for the patient. Equally, if there is severe hyperglycemia also, it is not good for the patient. So especially hypoglycemia can mimic as a stroke, so you have to treat the patient for hypoglycemia itself. What are your investigations? Like already I have said you, coagulation profile, complete blood picture is very, very important for looking in for. And then what is the next thing? Your scoring, NIHSS scoring components. What are the components? There are various components. We all know you can get it downloaded and calculate. What is important for us is looking into your level of consciousness, orientation. These are few important things which you have to look in for. The motor function, the facial movement. So these are second important. Of course, the sensory and all may not be able to be calculated in the emergency department, because if you start looking into such deeply, you may miss out. But what is important is your interpretation. Mild is 1 to 5, mild to moderate is up to 14, severe is 13 to 24, and very severe is more than 23. So this is what you have to look for. Now, what again? Now, NIHSS score is all been calculated. Now I'm going to the treatment part. Now, what should I do now? So again, I would like to see your understanding this. So we'll go with the second question for the stroke. So this is the second question. You can all note in for and then answer accordingly. Hope you could see the question properly. Good to see many are answering the questions. Okay, we'll end the poll now. Thank you for your answers. Okay. So now we'll continue with the next management part. You can see what is the management. We all know there are 2 drugs which is important here. And what are the other things which you can do? The other things which you can do is to avoid what are the inclusion criteria and what is the exclusion criteria. When should I treat the patient? That is an important thing. So initiate as early as possible for those who are eligible for fibrinolysis or mechanical thrombectomy. And imaging is only to exclude intracranial bleed before fibrinolysis. That is the reason why you do. Now, what is important is you can do a non-contrast CT or an MRI, CT angio with perfusion, or MR angio with diffusion weighing imaging with or without MR perfusion. If there is no clear onset, then MRI is the best one with diffusion positive and flare negative, which can also help to select the patients who would benefit from fibrinolysis. So keep in your mind, friends, the only thing is always CT is the best one. No need of MRI, because MRI always takes a time. But as per your hospital protocol, you can continue it. But the gold standard is always CT angio with perfusion. So that is why you're getting the creatinine level and then getting the CT angio. So this is how you have to look into the imaging modality. Now we all know, please look into this one and see that this is the normal CT. So you can see it here. This will become black. That means that the patient is having an acute infarct. So what is the difference between a bleed and an infarct on CT? It is simple to know. Whenever there is an infarct, you see as a black color in the CT. And whenever there is a bleed, you will see white in color. So this is how you can look into and decide whether this patient is having an infarct or a bleed. Whereas MRI, it is opposite. I will show you the pictures of MRI also. But since we use more of CT scan, we know we should keep in our mind regarding how it appears in the brain. And why this is happening? Like I mentioned, this is the normal vessels. Whenever there is a block in the vessel, you can see that there is that part of the vessel. After that part, it has been the blood supply is lost. That is the reason why that part of the brain is becoming black, because there is no blood supply. Now, what are the other aspects of circulation? You can also, because we know that we're not going to treat the dead brain. Our importance is the penumbra, which is surrounding the infarct. So that one you have to get it back. That is the reason why your treatment has been given. So how does it help? There are a lot of softwares which have come in now. One of the software which many hospitals are using is the rapid software, where it uses the criteria, something called as Alberta Stroke Program Early CT Score, that is aspects. As per the score, you look in how much of penumbra is there, and then the treatment is also being initiated. That is the reason why this 3 to 4.5 hours has become totally into 24 hours. Because with all these studies, putting into these softwares, you can decide whether this patient requires a treatment or not. And this is how you can look in how the perfusion studies will be available. So when the patient is following up, you can see here how it is becoming black, that is acute infarct perfusion study. And when there is a follow-up, you can see that there is a total infarct of the patient. So these modalities with the medicine going in phase and phases, we should also be acquainted with what is going on. Now, the diffusion weighted MRIs, what I said. So with this, what you're going to see, you can see here how it is there. So posterior circulation stroke, anterior circulation stroke, and the middle cerebral stroke, that is involving the vessels, that is the posterior cerebral artery, anterior cerebral artery, and the middle cerebral artery, which has been getting involved. And that is what you're seeing in the diffusion weighted imaging of the MRI scan. And this is what you're going to see in various signals intensities. There are 3 intensities which we keep using. This T2WI is a marker where you can see here the stroke which is here. It is almost normal. It starts increasing only in the later. Why I'm telling all these things for you all is because we emergency physicians, even after 24 hours, 48 hours, we are asked to get the imaging. So when we get the imaging, we should be aware that this is what is the changes which happens. And these are the studies which we see and look into and get it. This is what is about the diffusion weight imaging study, which you can see that it starts increasing immediately and then it starts falling down when you do the diffusion weighing imaging study. And also the ADC, which again, you can see here, it is not showing anything up to 7 days. And it starts increasing in intensity after 7 days, up to 30 days, you can see the infarct intensity on the MRI. So this is about the imaging. Let it be a CT scan, let it be a rapid software or your MRI. Now, what is important for us? That is your fibrinolysis. Who are benefited? Like what I mentioned, if the patient presents within 3 to 4 hours, that is the best time to add fibrinolysis and give the best results for the patient. So initiate without any wasting of time. That is very, very important. Don't waste your time in the emergency department saying that I want to change the clothes, I want to connect the IV line, I want to give an antibiotic, I want to take an ECG. This will all be delaying the time. Time is brain. Time is very important. That is the reason if you get a phone call, activate your radiology department so that you can shift the patient within 3 to 5 minutes should be the target of an emergency physician to shift the patient to the CT room. Now, who is eligible and who is not eligible? We all know that once the eligibility has been framed, okay, this patient has to be taken up for fibrinolysis. There are only two agents. One is your altipase, second is your tenecteplase. Of course, tenecteplase is not FDA approved, but still many departments, many neurologists utilize. So we will also go with the flow. As per your hospital protocol, you can do your treatment. Now, what is the dosage of altipase? Altipase dosage is 0.9 milligrams per kg body weight with a maximum of 90 milligrams. Out of that, 10% has to be given as a bolus dose. This 10%, what I was mentioning, you have to take the vial to the CT room. Once you detect that there is an acute infarct, please load the 10% of the dose and you can straight away give it as a bolus. Remaining dose, you can start in your emergency department, which will give you a leverage of time. Now, when should I start? Our ideal criteria for starting this one, it should be less than 40, 80 years of age, but there is nothing like that. Today, even 90 years of age, if the neurologist decides, you can go ahead. And without diabetes mellitus or prior stroke is an ideal one, or the NIHSS score should be less than 25. That is what has been said. And if the patient is not on anticoagulants, that is another important thing. And whenever there is an ischemic injury, not more than 1/3 of MCA territory. So these are the ideal criteria for starting your fibrinolytic agents. What is the difference between altipase and tenecteplase? Tenecteplase is a single bolus that is 0.25 milligrams per kg body weight. So you take 0.25 milligrams. If it is an 80 kg male, you can straight away calculate and give up the doses. So this is how you have to be very fast in your fibrinolysis. There are many contraindications. There are absolute contraindications and relative contraindications, which all of you are aware. So I'll be moving on. But very important thing is your blood pressure. Whenever the blood pressures are very high, ensure that you reduce the blood pressure before you give the fibrinolytic agents. Now, what major problem will happen? There are not much of a problem which we have seen or encountered. The angioedema, which has been mentioned here, is very, very rare, but sometimes it can happen. So whenever it happens, we emergency physicians, we know what we have to do. Keep adrenaline, which is always ready in our emergency department. So take it 0.3 ml. Either you can give subcutaneous or you can give nebulized dose of 0.5 ml. So that is how way you can treat the angioedema. And what else you can give? You can give diphenhydramine or methylprednisolone or ranitidine if the patient is having mild angioedema. If he has a severe one, there is no other go, start him on epinephrine. So this we have to keep in our mind. Now, what next? When you are doing a fibrinolysis, what can happen? So one is angioedema, second is your intracranial bleed. So whenever there is an intracranial bleed, you suspect an intracranial bleed for the patient, please ensure that you stop the drug, then you reassess the patient, or if required, you can do the CT scan and then take the forward for the treatment. What is your next problem which can happen? Blood pressure. Whenever the blood pressure is more than 180 by 105 millimeters of mercury, then again you have to reduce the blood pressure and restart the altipase. What else can happen? You know, there can be a severe headache or vomiting or any other bleeds which can happen. Then you have to be careful and see that you cut out the drug and again get the CT scan urgently, and then you can restart the patient if there is no IC bleed. So when you suspect or there is this IC bleed which has been proven, what you have to do? Cut off the drug, take the patient to the CT scan, again restart your workup, that is send the coagulation profile again, get the plan, you have to get the FFPs ready, cryoprecipitate, factor VIII, and also fibrinogen products. So keep your that is the reason why you activate your blood bank, so that they also know that there is a patient which is there, fibrinolysis is happening. And when there is a midline shift, neurosurgeons will come down and they will take, or either they can do a burhole or they can take to the OT. So that is, these are the things which we have to keep in our mind. So this is another last interesting poll which I would like to show you. So I hope all of you are able to see the question. Yes. Which is not an absolute contraindication to fibrinolysis. NIHSS is a 4, intracranial bleed, arterial puncture, suspected aortic arch dissection. The second question is, someone has a stroke signs and symptoms. CT shows an hypertense area. What to do? Fibrinolyze as early as possible, discuss with the neurosurgeon, do an MRI to be certain, or discharge the patient. Which score helps in radiological grading of stroke patients? Rapid AI, aspects, dawn, diffuse. So there are 3 questions and hope you can answer it within next 60 seconds. Thanks for your answers. Sorry. So many a times people keep asking me when we can restart the oral feeds. So there is something called as the agglutination test or dysphagia test, which we commonly say. So whenever to rule out angioedema, the best thing is give him a cup of water. If he's able to drink it, that means that there is no angioedema. If he's drinking normally, if there is any signs that there is a, if he starts regurgitating or if he says that he's unable to drink, that means that dysphagia test is positive and you are not supposed to start him on the feeds. If he's tolerating, then you can start the feeds. Now, what is the next line of treatment? If there is no fibrinolysis, many a time today, most of the interventional neurologists plan to do the mechanical thrombectomy. We all know why the infarct or a bleed is happening. That is because of the clot which is happening in your arterial system. That is the reason why there is an infarct or a bleed. The same thing which happens in your myocardium. There is a block, so infarct is happening. So we have to be careful and look into, and that's the reason why they take the patients also. Mechanical thrombectomy has become a treatment today of standard of care. Now, where they are going to do and what are the indications, everything which has been shown on your screen. Most of the non-invasive vessel imaging for the mechanical thrombectomy, let it be intra or extracranial. So both, either it is vertebral artery or carotid artery. So here, what do we have to do? They straight away take the patient to the mechanical thrombectomy and look into the arteries. Then they will do the thrombolysis there or catch hold of the clot and take it out. That is what they do. And within 6 to 24 hours window with large visual occlusion in the anterior circulation, we have to get the CT perfusion or diffusion weight imaging of MRI with or without perfusion. Then they will decide whether this patient can be taken up for mechanical thrombectomy or not. So this is how you can look in for. And what are the indications? It can be up to 6 hours. There can be a pre-stroke MRS score of 0 to 1. Occlusion of
internal carotid artery or middle cranial artery of segment 1, age 18 years of more, NIHSS score of 6 or more, or aspect score, that is the rapid software which you are using with 6 or more of a score, or if there is an M2 or M3 segment which is reasonable. And then also you can look into the anterior circulation. If they meet the Dawn criteria, they can be involved, and it's a coordinated teamwork again, wherein the neurologist will come into picture, and then it is the interventional neurologist which usually does this one. Now the next important point is about when to start antiplatelet agents. Antiplatelet agents should not be started within 24 hours. It should be, sorry, I'm very sorry. It should be started within 24 to 48 hours. If fibrinolized, then you can delay for at least 24 hours, and then you can start the antiplatelet agents. If a patient is in minor non-cardio embolic stroke, not requiring fibrinolysis, then please ensure that you start a dual antiplatelet agent within 24 hours and to be continued at least up to 21 days. So that is about the antiplatelet agents. Now, altipase versus tenecteplase, there are multiple studies, and this is what there was a systematic review with meta-analysis of at least 8 trials, which was 6 randomized control studies and 2 observational trials, with almost including 2031 patients. That means that this is a huge number of trial, and there was seen that there was no difference in good functional outcome at 3 months. But tenecteplase showed better recanalization when there is an early thrombolysis which has been done. So these are the results of these patients, but I'm not recommending whether to give tenecteplase or altipase. It is the hospital-based protocol which you can follow and have a discussion. Now, what is the next thing? Cerebral edema. Cerebral edema is very complicated, and many stroke patients, if you don't treat, that is where they become vegetative stage. So with large territorial infarcts, we are always know that there is a risk of herniation. And what is the treatment? We know that it is decompressive craniotomy. And what we as emergency physicians have to do, we have to give the osmotic therapy, that is, let it be your mannitol or 3% saline or whatever your hospital protocol mentions. The standard of care, you have to follow it. And whenever there is moderate hyperventilation, the target PCO2 should be between 30 to 34 millimeters of mercury as a bridge. This can be used only when the patient is to be shifted to the OT, and this can be used as a last activity which you can do. Even in case of a bleed, which let it be the traumatic brain injury also, we do this maneuvers and ensure that we do a moderate hyperventilation, but keeping in mind the target, the carbon dioxide, which has to be kept. So this is another important thing which you have to keep in your mind about cerebral edema. Now, we all know the AHA guidelines, that is a stroke algorithm for every hospital. Please take a printout, keep it in your emergency department so that the residents who join you, they will understand why it is important and what guidelines they have to follow and what is the algorithm they are going to see. So most important is, it is the timeline, patient coming with the pre-notification, receive the patient in triage, that is the resuscitation zone, look for a neurological examination, activate for the stroke protocol, collect for the investigations, shift the patient to the CT room, activate the CT room that a patient with stroke is coming, get the CT imaging with angio, if required, rapid software, which is already inbuilt. So you can look into whether it is infarct or bleed. Infarct, target is your treatment with fibrinolysis if the patient is having indications. There is contraindications, please try to avoid, and you can decide the drug whether it is altipase or tenecteplase. Once you are given the treatment, that should be within 60 minutes of the patient entering into the emergency department. If the patient has to be completely shifted out of the emergency department to the critical care area, that is, your target should be within 3 hours. So that is what is your stroke protocol, which you have to follow in every hospital. Now, what are the other indicators? Many hospitals have their own quality assurances. They will divide the stroke pathway into 3 or 4, whether this patient is shifted within 10 minutes to the CT imaging room, whether the patient's reports have come within 25 minutes from the CT, from 0 to 25 minutes, and whether the patient has been started with fibrinolytics within 60 minutes. So these are the quality indicators you can keep in your emergency department and monitor them, which is very, very important. So how do you monitor? Okay, you're monitored, then what is the next step? Team meetings, which will keep you always on your toes. Let it be weekly, bi-weekly, or monthly. You can decide upon. Take the number of patients who have come with stroke in that month. So how many thrombolysis have happened? Check out whether the thrombolysis been rightly done on the pathway, then only it will be correct. Otherwise, again, you're not going to do anything good for the patient. So your benchmark is your best practice. And as I started, right patient at the right time to the right place will give the best care for the patient. So with this, I would like to say, when you do it in an organized way, the mortality, the morbidity, the most important thing, disability is reduced. When you reduce the disability of a patient, you are going to say that, okay, you have treated the best for the patient. You have given your best and you're reducing your complications. When you do all these things as a teamwork, the independence, what the patient wants, you have given it back to him. So always we are proud to be emergency physicians because we know what to do at that particular moment. Thank you all for listening patiently for this lecture. So any questions, any comments, we are ready to take it up. Jude, Dr. Jude, over to you.
Yeah. Thank you, Srinath, for the clear and comprehensive explanation in a detailed manner for the various multimodalities of treatment aspects, the investigating components, and the impact that it leaves with the patient. Everything has been wonderfully explained. And without wasting much time, we can take one or two questions from the forum. That is, one question has been asked by Chintal Palan. Can we give D25 in hypoglycemia with acute hemorrhage, though it is hypotonic saline? This is the first question that I can see here.
If a patient is in hypoglycemia, we all are aware that we have to correct their sugars first. That means that you have to give 25% extras.
Yeah, that has been very beautifully explained, because hypoglycemia can be a mimic of acute stroke itself. So we have to definitely correct it before we take a treatment decision for stroke. The second question I can see here is, can we thrombolyze a patient with wake-up stroke? That has been already explained by Dr. Srinath. And here, Srinath, by your words, you can just explain that. Can we thrombolyze a patient with wake-up stroke? What is the ideology?
Yeah, as I mentioned earlier, the maintenance of the time, that 0 minute, is very important. But since in most of the patients who come to emergency department, we know that it is wake-up stroke. So that is the reason why the window period has been extended from 4.5 hours to 24 hours. When you subject them, whenever these patients come in, you subject them with the diffusion weight imaging, that is your DWI with MRI scan. We know that where is the perfusion, and then the interventional neurologist will be the best person to decide whether this patient has to be taken up for mechanical thrombectomy or thrombolysis.
Thanks, Dr. Srinath. Any other questions? So it was wonderfully explained that the three important points that I can recollect from the speech of Dr. Srinath is that every hospital should have a separate, exclusive, unique stroke pathway and a mechanism to dispose that code stroke. So that's the one important thing. And every efforts is towards to make a reduction in the disability of the patient who is suffering a stroke. And the final important thing is that quality assurance, how we can maintain the quality by keeping certain markers to ourselves and by redoing the meetings again and again with the team, which is stroke. So all these things has been wonderfully mentioned by Dr. Sir. Any other questions that we can take? Or we can hand it over to the chair who is conducting the program.
Any other questions are there on the Facebook also? We'll try to answer it back. We'll present the answers. So, because there is a Facebook Live which is going on.
Srinath?
Yeah.
Dr. Srinath, yeah. Any comments or your experience on giving, you have beautifully explained about the antiplatelet therapy. What is the protocol or idea of your team between a single antiplatelet therapy and a dual antiplatelet therapy? What's your idea? And what about giving an anticoagulant in some special situations? Say, for example, if the patient is throwing some AF or some thrombus sitting in the LV. Any inputs from your team and your expertise you want to share with us?
As the standard of practice, as I mentioned, dual antiplatelet therapy is the need of the hour. So that is what all of us follow, as you are aware. The second one is about the anticoagulant. I don't have much experience on the anticoagulant because it's not been practiced in many places.
Yeah. Okay. We also don't give anticoagulants for stroke as a routine. Some of the peripheral centers they do, and thanks for the answer, Srinath.
Thank you. My take-home message for all the residents who are watching online, offline, or everywhere, the BP management, because many times I've seen that Calcigard, all these medications have been given, especially NTG, they start off. That is very, very dangerous. Please don't start these drugs because these are not specific for the reducing the blood pressures, arterial blood pressures. And labetalol is very proven, it is very efficient. So last word is act fast again to avoid the patient going into vegetative state. Teamwork has no substitute in any place. Like what you do for code blue or code MI or code stroke or code sepsis, it is a teamwork. Involving everybody, bringing them together is important. With these few words, thank you, Dr. Jude, for moderating the session.
Thank you, Dr. Srinath.
And thank you, Dr. Naveen, for setting up this wonderful platform. And thank you, Mr. Pavan, who is my branding team, and Sundar, who have been helpful. Thank you all.